Hey, this is Dr. J. I'm here with Dr. Tyna Moore, the regenerative injection therapy specialist. Now, before you start thinking it's steroid injections, which are absolutely garbage and they destroy your joints, it's not. So this is something that was absolutely mind-blowing to me. You're definitely going to want to learn about this. If you've got bad knees, bad shoulders, bad hips, you're looking like, oh my gosh, my joints are falling apart. There's actually solutions, there's actually hope. And there's things that are natural, and I went through it. So stay tuned for this podcast, and you'll see my experience along with learning from the expert on what you need to know about it. It's going to be a great one.
Welcome to the Detox and Nutrition Coach Podcast. The following is for educational purposes only and is not intended to diagnose, treat, cure, or prevent any disease. Please seek the advice of a healthcare professional before changing your health program or embarking on a new one. And now, the man that simplifies the complex, your host, Dr. J. Davidson.
Hey, I'm with Dr. Tyna Moore, DC, Doctor of Chiropractic, and ND, Naturopathic Doctor, a rock star in this world of what I would say injection therapy. Is that safe to say?
Regenerative injection therapies.
That sounds a little bit better. Regenerative therapy injection therapy.
Regenerative injection therapies.
Regenerative injection therapy. So I'm a trained DC, super not good to admit, but I was very foreign with this whole injection therapy world. Prolotherapy, PRP, stem cells, and you introduced it to me.
Right.
Because you knew of my knee injury, and I was like, I don't know. And then you're like, no, I'm really good with knees. And all of a sudden my eyes are like, there's this whole world I didn't know about that could be so helpful for so many people.
Right.
So first of all, I want to welcome you to the podcast.
Thanch you so much for having me. Yes. Number 2.
Yeah. The first one was why a strong butt is important. I think was the title. So, which was a popular one. Probably the title itself helped. So we'll link that up in the show notes as well too. But today I want to drill you and really get more information from you, Dr. Tyna, on injection therapy.
Sure.
Or regenerative injection therapy.
Yeah, no, I'm happy to talk about it. This is what I specialize in practice, and so it's the bulk of what I do every day with patients. I think a lot of people don't know that about me. When people see me online, I'm usually talking about strength training or other things. So this is my first true love, and I'm happy you're here. I'm excited we got to treat your knee a few times, and you're improving. So
yeah. Like I just had a treatment 24 hours ago. Moving, I mean, this was my third treatment, definitely. I mean, something I would do again if I had to. But, just keeps to improve. So going into the injection in your wheelhouse, talk to me about what is regenerative injection therapy.
So it's a family of treatments, and the premise of all of them is the technique of prolotherapy. So prolotherapy, when people think about it, or maybe many have not heard about it, but when they do hear about it, they think of it as sugar water injections. And so it's been around since the 30s. It was developed by a doctor named Hackett, and it's basically the idea that we inject ligaments and tendons where they meet bone, which is called the enthesis point. And that's the area it's highly innervated, so it's very painful when it gets pulled or disrupted or damaged, and that is the area of high tension where ligament and tendon meet bone. So when it becomes unstable or the ligaments have been pulled or stretched, like when you sprain an ankle, most people have sprained an ankle, and they find that the integrity of that area is not the same anymore. It's a little bit looser. Same thing with the knee, same thing with your back. Same thing with any joint, really. So when ligaments and tendons have become compromised, they really don't go back to their starting point, much like a rubber band that's been overstretched. So we inject them with different solutions, predominantly dextrose, prolotherapy, or glucose, same thing. And the idea being that it calls up the immune system, it activates the immune system, and it gives the body a secondary chance at a modulated inflammatory response. So what's the first thing that happens when you hurt yourself? What were you trained to do in school? Same thing I was probably trained to do.
Rice.
Right. So rest it, ice it, compress it, elevate it.
Yep.
And that's exactly what you're not supposed to do. When you are injured, your body goes through a healing cascade, right? And we were all taught this in school. And the first 14 days of that healing cascade is the inflammatory cascade. And each part of that cascade ultimately finishes up with collagen production and collagen deposition, right? Collagen laydown, so that you sprain an ankle, you injure, you disrupt ligaments or tendons or soft tissues, your body goes through a whole healing cascade. It takes about 300 days, and the end result should be healthy collagen deposition. Well, everybody and their mother, especially in this country, is taught to ice it and give NSAIDs, right? Non-steroidal anti-inflammatory drugs, and that completely shuts off the first portion of that cascade, which is the inflammatory cascade. If that part of the cascade doesn't happen, neither will any of the others. They're dependent on the last to go to fruition. So we're compromising everybody's ability to heal in a sound fashion by dumping NSAIDs and ice on them.
So essentially, if I was to roll my ankle, it swells up, you don't really want to ice it then?
No, I encourage patients to keep it moving and to heat it.
Okay.
I'm actually trying to modulate inflammation, or in naturopathy, we treat it with a combo of ice or maybe cold and hot compressions. So we'll do hydrotherapy alternating. And I have a thing on my website about that we can link up to. It's just a quick little, like, how do you do hydrotherapy? But sometimes, and most often when people get that inflammatory cascade disrupted, they end up 300 days later with a compromised joint that hasn't quite healed up. And so I go in with my needle and my syringe, depending on what's in my syringe, and I inject those areas that have been compromised. I inject inside the joint to induce healing, and the cascade that happens from there is actually healthy new tissue gets laid down. Fibroblasts get kicked up, which lays down new collagen. Chondrocytes, which are the cells that make your cartilage, get kicked up and induced, and you get new cartilage growth. So the premise of it is prolotherapy as a solution, and then as a technique, what I want to really emphasize is that when you, like your knee, for instance, it wasn't just let's shoot some juice in the joint. Any monkey can shoot something inside a joint. The real art is treating all the ligaments and all the areas that have been compromised and stretched and pulled. And so for you, yours was a particular, you're post-surgery, you'd had surgery, so it was a matter of like reintroducing healthy new tissue into that region that was scarred up and weakened, right? So that's the technique of prolotherapy.
Okay.
Is that clear?
Yeah.
Okay.
Yeah, that helps a lot.
And so then we can grow up from there with stronger and better solutions. Something like platelet-rich plasma gets a lot of airplay and a lot of people talk about it, and it's, all the celebrities are doing it. Platelet-rich plasma is simply a stronger, more potent solution, and we can talk about what it is in a second, but it's the same technique in my world. I do the same exact technique, I just have something different in my syringe.
Okay.
And then there's stem cells, which is an even stronger solution, more potent medicine inside the syringe, but again, doing it in that prolotherapy fashion, I feel is really important. So I tell most doctors who are interested, unless you're good at prolotherapy, you really have no right playing with these stronger solutions.
Because it's the same technique, essentially. It's like the same foundation basis you need.
Exactly. It would be like having some kind of fancy adjusting instrument, but if you're not a good adjuster manually as a chiropractor, do you see,
Yeah.
So that's
the
kind of...
tool doesn't fix maybe the lack of your ability.
Right. And so a lot of patients come in and they're like, I want PRP, I want stem cells, but they might just be a prolotherapy candidate. And it's very affordable. I think it's, if you can find a doctor in your area, I can provide a link where people can look for that. But finding a good prolotherapist in your area, it's an affordable, wonderful treatment. And people just really don't have to live with and be hung up by these naggy, terrible joint issues that are really diminishing their quality of life.
Well, and that's the breakthrough that I see with this whole piece is, wait a minute, you mean a joint where the cartilage is minimal or gone or torn apart, ligaments that are overstretched because you've rolled your ankle 4 times, like you can actually do something for it. That's what was mind-boggling. I'm like, I'm a trained chiropractor. And yet it was not a tool I ever understood until more recently. We
were taught in chiropractic college that that it's scar therapy, that we're actually causing scar tissue to build up, and that's what's, welding the joint down, that's incorrect. It induces normal, healthy tissue regeneration, whatever tissues need to be regenerated. So platelet-rich plasma is simply taking the patient's own blood, spinning out the platelets. The platelets have 20-some known growth factors in them. There's about 5 of those growth factors that I think are most critical. They induce new tissue. They induce new blood vessels to the area. They do all kinds of cool things. And we take that concentrated platelet blood and we do the same technique and we inject it into the structures that are compromised. And so that's a beefier version. So if prolotherapy is tea, PRP would be coffee, And then stem cells, I think of them as more of, espresso. So
Okay.
a little more crack. A little more bang for your buck.
That makes sense.
And really just meeting the patient where they're at. People come in wanting these fancy treatments or saying, my doctor suggested this, and it's like, well, let's start with what works for you. If you're a really healthy individual, you're fit, you're eating well, you might mount a really wonderful response with just prolotherapy. And then we can always grow it up from there if we need to. But that's basically it. I mean, they're very simple in concept. They're only as good as the patient's own cells are. I think that's a really important thing to emphasize, is that I think it's a bit unethical to assume that somebody who is morbidly obese, eating very poorly, maybe very diabetic, dealing with a lot of health issues, they're not going to get the same response that you're going to get. Your blood is very different than someone else's, very different than my blood. As a female, I have different hormones. I have a different milieu, and so my cells and my platelets are going to be very different. And my healing response is going to be very different than a young man's who's got testosterone and, whatever differences in hormones that we have.
So in other words, I mean, prolotherapy, PRP, stem cell, it doesn't fix a bad lifestyle.
No, not at all.
Meaning clean your lifestyle up regardless, and then this is a tool that the healthier your body is, healthier your lifestyle is, the better results you'll get, basically.
Absolutely.
Okay.
And that's what brought me to the online world. Was I was just trying to not only get that message out, but to provide content that I'm building slowly to get people to understand that, so that they have the tools. Because A, it's only as good as your cells are. It's only as good as your homeostasis. And two, there are ways to optimize that. And so those are the things I like to speak about. It's like you can optimize your own stem cells naturally. You can optimize your platelets naturally. Maybe you don't even need these treatments at that point, but if you do, then we've got a much better chance at getting great results versus mediocre results. These treatments are not covered by insurance. They are considered experimental by Medicare, so no private insurance company will actually cover them. Some doctors are billing for them. That's fraud. To be honest, it's insurance fraud, and so it's an out-of-pocket expense, and I just find that I don't feel ethical providing that to a patient who's not going to get optimal outcomes. I'd rather work with them or send them to somebody who will work with them to get them optimized, and then we can apply these treatments, and we'll get a much more robust response out of it. So
yeah, well, typically things that are not covered by insurance are usually the areas we actually or the things that we want to do.
Right.
So maybe back it up a little bit. I mean, so I came here, I believe, at the end of November, and then I was here very beginning of January, and then now third time in February here. It was like a 6 to 8 week lag time, and we can talk about that too. But what was recommended before I came here? You gave me some recommendations. You said, get some, be good lifestyle, basically. You said make sure your diet, is good, get some collagen in. Are there any other, recommendations that fit there? So
I think number one is diet. So I tell most patients to go on an anti-inflammatory type diet, particularly just getting sugar and alcohol out or down as much as possible.
Okay.
Grains are very inflammatory. The reason being is it will affect outcomes for sure as far as how well of a result or how good of a result we get, but more importantly, when we're looking at stem cells or PRP, if a patient's inflamed or they have inflamed blood, and I take that inflamed blood and I concentrate it down and I shoot it into that hyperinflamed joint, we have a hot mess on our hands. And I've seen it. I've done thousands and thousands of these treatments, and I can usually call it by looking at the patient. Maybe we should run some blood work and see where we're at first. But really emphasizing the low inflammation diet, which you probably talked about several times on different podcasts. Inducing collagen production requires collagen, so eating collagen. Unfortunately, I don't know, there are no vegetarian resources for this. There really aren't, and so that's a harder time for vegans and vegetarians. But one of my mentors told me you have to eat collagen to make collagen, and I'm trying to induce collagen production with the injections. So really bumping up the collagen, and that can be as inexpensive as getting Knox gelatin. Or you can get the fancier grass-fed versions, whatnot. It's all animal product, though. And then vitamin C and zinc help induce collagen production, so I usually have patients go on that. Not a crazy high level, but something. Most people are deficient in zinc, and most people are missing vitamin C as a minor nutrient that they need. And then just being conditioned, I think, helps. I know that's why
Like exercise condition?
That's why I'm such a fanatic about strength training, is because the bulk of patients who come in to see me originally, I started pre-screening people to some degree before I let them in the practice, but the bulk of patients coming to see me were really just dealing with major deconditioning. They were, for lack of a better word, their joints and body, their tissues were just sort of dissolving off their spine. And we talked about that a little bit in the last video.
Yes.
And the last interview. I think that that's really a huge problem with people. This is a heavy joint. So if you have chronic shoulder problems, but you aren't doing anything to condition and strengthen your shoulder muscles, which hold your shoulder onto your body, you're doing yourself a huge disservice. I can inject that all day long. You can spend thousands of dollars, but we're not going to get nearly as far. We could cut the pain a little bit, but you're still going to be dealing with that ligamentous pull, right? And we talked yesterday when I was treating you about men who sort of end up with the big pendulous belly.
Yes.
And they don't do anything to keep their glutes strong. And so now just mechanically think about that. A big heavy belly on the front, nothing on the back to counterbalance it or to hold it together. And what is that doing to their spine? They're just literally hanging off of those ligaments. And they're hanging off their ligaments in a way that's pulling forward. So no wonder their discs blow out the back and herniate out the back.
Yeah.
The only reason a disc would herniate out the back is because the ligaments that are holding the disc in are weak or compromised. And that's nutritional, but it's also just that constant. We learned it as hysteresis in school. Did you ever learn that term in school?
Yeah, I probably blacked it out.
I know, right? I like the word because it's creep. It's the idea that if you sit all day and you just sort of hang on your ligaments, they will eventually just start stretching out. That's hysteresis. They just creep.
Deform.
Mm-hmm. And they stay there, and then that person goes out and does, your desk jockey goes out and does some vigorous, all chiropractors love Monday morning because that's when everyone comes in hurt, because they go out and do vigorous gardening or weekend warrior stuff, and they've got this sort of creeped back where everything's deformed and loose, and suddenly they've hurt themselves. So.
Yeah, well, that last interview, you definitely have to check it out, because that reshaped how I look at the population. After you said that, really we should have nice butts or glutes and not huge, bellies. Mm-hmm. And the population, for the most part, is the opposite. Big guts, no butts. And I mean, literally, it's like everywhere when you start looking for it.
And no one's talking to them about it because most doctors have the same problem.
Yeah.
And I'm calling them out because most doctors are dealing with the same deconditioning. And it's like, biomechanically, that just doesn't make sense. I mean, we're upright animals. And to do so, we need to have a strong posterior chain. And that's, a good set of glutes keeping us together.
So check out that last podcast for details on how to build your butt muscle, right?
Yeah, or why it's so important.
Yeah, that too.
Just to convince people. And I think that the take home with all of this is that I don't think people know it exists, these treatments, and they're really quite affordable when you look at them as opposed to surgery and what surgery looks like. I think that people want to use their insurance, and so they get hung up in that model, and the alternative is getting shot up with cortisone. Mm-hmm. Cortisone inhibits your immune system temporarily, which decreases your inflammation temporarily, and then long term it completely disintegrates your tissues. So we've got an unstable ligamentous structure, an unstable joint, an unstable tendinous insertion area, and now we've got cortisone in there, which slowly but surely disintegrates the joint. So now we've got a super hypermobile, lax joint, and what happens on the inside is you get a much faster rate of erosion. And when knees don't slide the way they're supposed to, they grind all over, and you get a tremendous amount of arthritis in there. So cortisone, very short-term fix, long-term, pretty devastating to the joint. And we're seeing that in studies. They're looking at long-term studies, especially like lateral epicondylitis. People's elbows are dissolving. So it's terrible stuff. And
I think that's where, when I first, obviously I've heard of Prolo, I just automatically threw it in the cortisone category. I'm like, oh, it's injection, right? And just completely wash it off. And then when I actually asked you, I'm like, hey, do you know a good orthopedic surgeon? You're like, what? Like, no, let me help you. Yeah, like, let me help you. I'm like, what do you mean, And all of a sudden it was like, oh, my world's open. Mm-hmm. I now understand there's another level, but I was walled off. I was shut off.
Sure. Well, people don't know, and I think a lot of people assume when I say injections, they assume cortisone. Cortisone's devastating. It's catabolic, which means it chews up your tissues. The other option that's popular is hyaluronic acid. Hyaluronic acid is very expensive. A lot of insurance companies are not covering it anymore because it's not very efficacious, and it's in and out of the joint very quickly.
Okay.
It basically is coxcomb, so it gives you some slick, it gives you some lubrication in the joint. And I think that I would say some people have had some decent success. It wears off pretty quickly. It's not regenerative. So all the treatments I offer, literally, slowly but surely, depending on the potency, how quickly, they regenerate your tissues, normal, healthy tissues. And so you're not going to overdo it necessarily. The adverse outcomes are very rare. I think infection is probably the biggest risk, but if you've got somebody doing clean technique, standard of care, there's no real problem there. I've never had one, knock on wood. It's their own cells, it's their own, or it's sugar water, which is very benign, so there's no adverse reactions, there's no contraindications. There's really the only contraindication is being allergic to local anesthetic, which I rarely have found, and I always pre-screen patients for that. If you've been to the dentist and you've had something numbed inside there, you've had a little skin lesion removed, you've had local anesthetic, and you're probably safe to go with these treatments. So super safe, very available to people. I guess depending on where they live, they might need to find somebody who's trained in it. But more and more doctors are getting into this because I think more and more doctors are realizing that cortisone is a no solution. And so the other option is surgery, of course.
Which push that off as much as you can. Look at other options.
You can't undo surgery.
So talk to me about the time frame. So I came here end of November, and you said around 6 to 8 weeks. I mean, compared to like hyaluronic acid, which you said was kind of in and out, and it's obviously it's not regenerative either. I mean, why 6 to 8 weeks for PRP?
That's just what I found to be best. We all have all of us practitioners doing this have sort of a different protocol.
Okay.
With prolotherapy, traditionally, it's one treatment a month for 4 to 6 rounds. And that was the old way of doing it before we had PRP. PRP was introduced in the early 2000s. I was fortunate enough to be working with my mentor, Rick Marinelli, who's now passed, and he was one of the first people to start doing PRP orthopedically, at least in the naturopathic community. And I was one of his first patients. I was one of his first guinea pigs, and I had lots of prolotherapy at that point. And when he introduced PRP into my back, I was like, oh my gosh, and that was it. I jumped from chiropractic college into naturopathic college so that I could have a license to inject. It was that profound. That's the whole reason I started doing it, was because it saved my back. So prolotherapy, you can see, is a bit slow going, once a month. And now you know that my whole stance is that movement is medicine. And so you're out for about 2 weeks from sport every time I inject you, right? And then the third week you can ease into it. The problem with Prolo, it's wonderful if you're better in 2 or 3 rounds, but if you're not, you're off for 2 weeks, and then you are trying to get moving again for 2 weeks, and then I treat you again, and then you're out, and it's a little bit redundant for athletes. For the normal person, that's fine, but for athletes, I think we all get a little crazy unless we can get back to the gym. So PRP is a better answer, I think, there. Kind of depends on the case, though. It's definitely case by case, but PRP, I found 6 to 8 weeks to be the magic window for people. Okay. And I usually suggest people budget for 3 rounds. Not always necessary. Often 2 rounds, they're great, or they're 90% better and they're happy. And that 3rd round is just kind of icing on the cake, but it's not always necessary. There are several doctors out there who will just say, we're going to do 5 rounds and then we'll reevaluate. I think that's complete BS, and I think it's unethical, honestly. I think if you're not getting your patient 70 to 80% improved in 2 rounds, you're missing the diagnosis. You're not hitting the pain generator. So that comes down to doctor skill, I think. Yeah.
Well, and being out a couple weeks, that's why this time, the day before I got injected, I'm like, deadlift, squat, heavy. I'm going to be really sore. So I got some time off. But the thing that I noticed about the treatment, so I went through 3 with you. The first one, I was scared to death because I'm like, surgeries, needles, I remember the first day in cadaver lab in chiropractic school. I walked in and I'm like white as a ghost. I'm like, oh man, just not my ballpark. So if I can do this, I think anybody can do it. But after actually the first time, I was like, okay, I get it. I get like I get during, you kind of numb it up and I'm like, oh, okay, I really can't feel much. And then I get the kind of inflammation and pain afterward. I would say my personal probably the first 12 hours, maybe 16 hours were like the worst.
Yeah.
And then 24 hours later was actually pretty easy movement-wise. It's hard to explain until you go through it.
But the thing is there's no downtime really. With prolotherapy, with dextrose prolotherapy, it's a mild ache for the first 24 hours, not a big deal. It kind of hurts so good, to be honest.
Okay.
With PRP, it's a little. I tell people, you're going to feel like you got hit by a train or got kicked by a donkey for about 24 hours, and it comes and goes. In a healthy individual, when I can look at a patient and predict how they're going to respond, I can tell them with decent certainty, 24 to 48 hours, it's going to hit you like a train and it's going to be gone just as quickly. And when it goes, it goes. There is the occasional joint or the occasional patient where it's, 3-4 weeks down the line, they're still aching. But generally, it's just a quick, robust pain. We give them painkillers if they need it, and then they're done. And that's the end of that. There's really no downtime. People go back to work same day. I treat a lot of chiropractors, actually, because, it's hard on your body to treat that many patients. And so a lot of them are just so hardcore. They're back to work same day, which I don't encourage. But you're not off. A surgery, you're off for weeks.
Yeah.
And then you're rehabbing and you're this and that. I do encourage rehab after you're done. So what we're doing is laying down collagen. The important part is getting that collagen to line up in functional patterns, right? We want them nice and linear and strong. And so that's where I think rehab and PT come in. And I think it's critical. And my patients who don't engage in activity following some kind of controlled activity, they don't do as well. So that is a part of the puzzle. And my patients who fail care or who say, I didn't get that great a result, they're also pretty stagnant people. Not always, but often they just don't follow through with that piece. So,
well, on my own note, I had surfing injury. Went out to big waves with my brother-in-law, who's the camera guy. He's behind the camera, smiling. Not understanding how to surf. Went out, ripped my knee apart. Did an MRI, everything looked fine except for maybe a little bit of, like slight arthritis type things. Mm-hmm. And then you pull up the ultrasound and you're like, oh, you can just tell the quad muscle right above the patella was all like jaggedy and it was ripped and torn. I'm like, after the injury, I had this huge lump, but yet nothing showed up in MRI. So where does the ultrasound come into the mix?
That is such a good question. I am decent at diagnosing with ultrasound. There are some people that are way better. That's their whole art. I use it more to direct the needle, but I can see abnormal from normal. And I've seen enough joints with ultrasound over the years that I have a pretty good idea of what I'm looking at. MRIs, and you can tell me if you think differently, but I feel like MRIs are written to justify surgery. So if they can't find something that they can do surgery on, that's really what they're looking for. And to their defense, that's their tool, that's their hammer, and that's also the standard of care. And it's also, they need an objective finding to deliver a treatment to protect their license. So I get that. But what I'm looking for is subtleties. I'm looking for where ligament and tendon meet bone. So I'm looking, compared to your right knee, we could see a significant difference. That was what was most interesting to me. And so I think that was a really nice thing. Of course, we could palpate it too, though. Well,
that was the thing. You were literally palpating, and you're like, you're palpating where the tendon met the bone, and you're like, oh, right. And as soon as where you felt it, I was like, whoa, that. And then you injected it. The second round, you're palpating the same thing. I'm like, there's no pain there anymore. Yeah. And now it was like, you were kind of peeling the layers back. Like, this is primary. Okay, we kind of healed that up. Now, here's some secondary. Healed that up, and then the third round just felt like was kind of the mop-up session of, okay, we're just going to make sure this is all solidified.
Thank you for saying that, because patients will often come in and they'll think, this is a one-shot wonder, and it's not. And I tell them that verbally. I write it down on the treatment plan. It's all over my website, but their hopes are so high, and they think some miracle is going to happen in the first treatment, and often they'll get significant pain relief, or they'll have a shift. Yeah. But really, you were such a wonderful patient to commit to the 3, because that's you just described it perfectly. The first one's kind of a shotgun approach where I do a big, bold treatment. The second one, I'm getting much more specific because the pain's centralizing down, and then the third one, we're just cleaning up any residual. You also had a really decent scar from your surgery, which I think was causing a lot of adhesion, and it was so indented and it was so adhesed down, and just really being able to release that scar and release, all of that scar tissue is giving you a lot more freedom of movement, which will help you to hopefully decrease your pain and your potential for arthritis. So it's it's a process. And so I think when patients will commit to giving me the 3 attempts, I get much, and that's almost where I love PRP more than stem cells. People come in for stem cells, and you've really got, it's a more invasive procedure. I've got to harvest the fat or the bone marrow. It's messy, it's invasive, it's more painful, it's much more expensive, and so patients will often only be able to budget for 1. But in a healthy person, 3 rounds of PRP cost as much as 1 round of stem cells, and so I can do so much more with 3 rounds of PRP therapeutically, just like you described, than I can with 1 round of stem cells. So that's where I more often than not talk people out of stem cells. I'd much rather have them have an affordable access point and have my 3 attempts, because I can do a lot with 3 treatments. That one treatment, that one-shot wonder that some people are expecting, that's just not realistic. Sometimes it is. Sometimes it's enough to get you over the hump. But
it's the culture. It's our culture in America, though. Yeah. It's like this magic pill, this one thing that's going to fix everything. Yeah. And I mean, yeah, it's just not the case. So give me some examples, body parts.
Okay.
And what have you seen? So you worked on my knee, I had a huge scar. You said the scar was inhibiting this whole VMO muscle.
Yeah.
So obviously knees is an area you work on.
Knees are huge. I think knees are my favorite because they respond the best.
Okay.
So each joint has its own endogenous supply of stem cells, meaning its own internal supply. And as we age, those get used up. They get activated and used up. That's why older people don't respond to these treatments quite as well. Although I've got plenty of geriatric patients I'm keeping out of surgery. So they do great. They're good enough. Sometimes good enough is just fine. Knees are great. Shoulders are one of my most favorite joints to treat because I treat mostly strength and conditioning athletes or people who lift. And I consider
former CrossFitters.
I got a lot of those. CrossFit makes a lot of us Prolotherapists a lot of money. Hot yoga too. Airline stewardess and stewards with the overhead bags.
Oh.
People this is my public service announcement. Check your bag. This whole overhead cabin thing, most people do not have the shoulder integrity to be hauling a 30-pound suitcase up and over. So just hopefully your audience takes that home with them.
Southwest, bags fly free.
Yeah, check your bag. It's worth the $35 not to have to come in and spend thousands to get your shoulder fixed. But shoulders are wonderful. I think it's just because when your knees are jacked or your shoulders are jacked, it completely ruins your quality of life. I just treated one of our mutual friends recently for a lateral elbow who he wasn't quite realizing that it was causing him so much trouble, but it turns out it was causing him massive issues with lifting. He loves to lift heavy, and he wasn't able to go up in weight the way he wanted to because this elbow. One treatment, and he said 90% improvement, and he's lifting heavier than ever. So elbows are great. I treat knees, I treat ankles, I treat pelvic floors, I treat spines, I treat ribs, I treat lots of post-whiplash people, Jolene Brighton.
In the spine? Okay.
Jolene Brighton, she won't mind me saying this. She's one of our Dr. Jolene Brighton.
Yep.
Your audience probably is familiar with her. If not, they should be. She's great. I met her when she was first out of school after a terrible car accident, and she says it. She said it on my Facebook that I saved her life. So we did PRP in her cervical spine. She was so unstable. I see a lot of women who have just had babies. They've got a lot of relaxin and a lot of loose ligaments from that, and then they get in a car accident.
Oh. And
they sort of just disintegrate.
Okay.
It's horrible. And so I see a lot of those. I love it for whiplash. I really wish that people would seek that out post-whiplash. I had a woman communicate with me today on Facebook telling me about her 20 years of horrible spinal pain following so many car accidents. And I'm like, honey, you need Prolo and PRP. It's really that important, and it's just so unnecessary to live with that kind of pain. I personally had almost every joint injected, and every single time I think, why did I wait so long? And my friends who are Prolotherapists, we joke when we get together, when we're at conferences, we're like, how do people live without this? It's so simple. Even just, you haven't even experienced Prolo. Prolo is wonderful.
Yeah.
Very affordable, very easy to receive, not nearly as painful as PRP, and it's like, for a healthy individual, just clean up the joint with some Prolo, a couple rounds, they're good. And their life is back. So,
what about wrists, hands?
Absolutely. Wrists and hands. I can actually release the median nerve out of the carpal tunnel with ultrasound and fluid dissect the nerve. It's very comfortable.
Wow.
No more surgery. Carpal tunnel surgeries are not necessary. They're usually a thyroid issue, and they're having swelling there because they're hypothyroid, and then we can simply release that nerve over a series of treatments, and so it's not adhered anymore.
Okay.
It's just ridiculous that people are getting their wrists cut open, and it's completely changing their life. They can't do their jobs anymore afterwards. So,
is there any off the wall areas that would be surprising?
Genitals. I put PRP in genitals. So I treat a lot of, not as much anymore, lichen sclerosis, which is a terrible autoimmune debilitating illness of the vagina and the penis. And so I've treated lots, but with autoimmune cases, unfortunately, they will return if the patient doesn't completely overhaul their life. So I've moved away from that as much. But for tissue rejuvenation down there, as women age, they start to have atrophy in the vaginal tissues and in the clitoris, and they'll start losing sensation. For men, similarly, for erectile dysfunction, works great. Scalp, I use PRP in anywhere that we need regeneration. So we can, and it depends on the scalp, but I can often get hair to regrow for many, many people. Depends on their balding pattern, of course, and male versus female. I use it in the face to regenerate face. It makes people look beautiful. It takes time, though. Healing takes time. Regeneration. Yeah. It's not like getting Botox or filler. You do PRP in someone's face, and you're waiting 4 to 6 weeks to see a diminished, they get more vital looking, their skin gets more taut, but they get a diminish in wrinkles.
Is it about 4 to 6 weeks for the PRP to kind of run its course then, inflammation-wise?
Yeah, and just
healing-wise?
So there's growth factors, and they lyse and they activate. And so they have from what I understand, about a 12-week life. Okay. And so I think 4 to 6 weeks is where we really see where we're going. That's why I usually call
But it can literally last 3 months then.
Yeah, and then they build upon each other. So that second treatment really sweetens the first one. You do 3 rounds of PRP into someone's face, and they're going to be beautiful for years. Years. They're going to have a regeneration of tissues. It's wonderful. But it takes time. An interesting fact I'd love to state is that some people, we get this often enough, people will call 10, 12 weeks later and say, I'm not happy with my results. I don't feel any better. Things haven't changed. And I say, come on in. Let's have a talk. Let's see what's up. And I kid you not, 9 times out of 10, sometime that week before they showed up in the office, they literally woke up and the pain was gone. And that's happened to me. I've been injected and woken up the next morning pain-free, and I've been injected, and 6 to 8 weeks later I wake up and I'm like, oh my gosh, all my pain's gone. So my mom she had the same experience. Just as an example, I treated her sacroiliac joints. Huge, right? In chiropractics, everybody's got low back
SI, or what people always call the hip.
Yeah.
But SI joint.
Hips are big, but I did her SI in her hip. She was a month later, she was very unhappy she wasn't any better. And then all of a sudden she's like, I literally woke up and all the pain was gone. With hips, I think it's really important to be aggressive. Hips have a very low endogenous stem cell population in there. They're persnickety, and you have to kind of hit them hard. But catching somebody on the front end, like right now I'm starting to have a little bit of arthritis in my hip. Now is the time to treat me, not 3 to 5 years later when it's degenerated. And I've got plenty of patients who are in their 80s that just are not going to have hip replacement surgery. They're too old, they like their life, they don't mind hobbling around a little bit, and we do PRP on a, annual basis, basically, and it keeps them in the game, and they're fine. I treat a lot of knuckles, a lot of arthritis in the hands. It's wonderful. Prolotherapy, just simple prolotherapy is wonderful for that.
You ever work with the RA deformity of hands?
That's tougher because that's an autoimmune. And so I really have to gauge the patient, and I've usually got them hooked up with a good naturopath, and we're working together to time it right. Sometimes we'll take them off their biologics and treat them, but I have to be very careful not to flare them. Okay. So that's a difficult, more like psoriatic arthritis, ankylosing spondylitis, rheumatoid arthritis. Those are a little dicier, but.
Gosh, I feel like we can just talk about this for hours because it's so new.
Yeah.
And I'm the first one to blame myself. Like I just wrote it off. Like, oh yeah, it's steroid injections. Like, it's like the last thing. You draw my blood out, spin it down. You're using the plasma rich platelets from my own body, so it's not foreign. And then you're applying in different areas. So
right. Something to note, just back. It rang a bell for me that I want to say because I get a lot of questions about this. Fibromyalgia, this is not a treatment for fibromyalgia. Okay. This is not a treatment for someone who has cancer because we're putting growth factors into areas, and that we don't want to help anything grow we don't want to, like cancer. Gotcha. So I don't treat people who actively have cancer. And I don't even put a needle in fibromyalgia patients. That's a whole different ballgame. That's usually a brain type of pain that's manifesting. It's not necessary. I mean, they might have an actual biomechanical issue they need help with, but 9 times out of 10 they'll flare, and they flare for a long, long time. So just something to let the audience know about because we get a lot of questions about that, and I wish that weren't the case. But
yeah, and just so that Dr. Tina's team doesn't get bombarded, we're gonna have a link and resources of what questions you need to know and ask. Obviously, if you want to come see her, then give them a call. But just calling her staff and just asking questions to find somebody locally, it kind of ties her staff up a lot. So we're gonna get you resources, make sure you're not out in the dark. But I think this interview helps so much just to understand it so much.
And my website has I've tried to make my website an educational resource for everybody. So there's a ton of information about prolotherapy, platelet rich plasma. There's a whole page on research. There's a whole page of testimonials. So just so people can have an idea, this seems new. It's been around for quite a while for those who've been doing it for a long time. I know the stem cell is definitely more. Dr. Harry Adelson is who taught me that, and he's wonderful. He's in Park City, Utah, if you guys want stem cells. But it seems so. I guess people are shocked more than anything. They're like, how could that possibly be? Why have I not been told about this? And sometimes people come in even a little bit angry about it.
Yeah.
So it is an option. It's not that hard to find. People fly out all the time. I get a lot of calls asking for referrals to somewhere else. A great website is getprolo.com. Find a doctor in your area. But I have a lot of people who fly in to see me in particular. I think a lot of this has to do with the technician. I'm not just trying to toot my own horn. I've been doing it for 10 years. My mentor before me, who taught me everything, I had a wonderful mentorship in this, so I really feel fortunate. But I am very good with a needle, and it's it's an apprentice type of thing.
Yeah.
And it's really the technician. A lot of orthopedic doctors are jumping on the bandwagon saying, I do PRP, and they shoot some juice in your joint and then you're gone. And those people end up in my office and say, I had PRP, it didn't work. Well, you had one shot into your knee. And imagine your knee in particular. Imagine if you just had one shot intra-articularly.
No way.
You maybe would have had a little pain relief, but that was not your problem.
Yeah.
That was part of your problem, but your problem was really other things. And so finding a good old school prolotherapist who has PRP at their disposal, that's what you want to look for.
And for practitioners listening, you also train.
I do.
Practitioners. So
I do a lot of training, predominantly other naturopathic physicians, and that's all on my website as well. And it's like that's where my heart is.
Best website is the core.
It's drtina.com. We'll get you there.
Yep, drtina.com. So we'll make sure to put that in our show notes as well, also on the video.
Yeah.
Too, but it's such awesome information. Anything you want to leave our listeners with?
Yeah, just that you don't have to be stuck with this chronic pain scenario that you're in most often. I want people to really seek this out and understand. I even have a blog post about it comparing the cost of surgery to the cost of these treatments and really just understanding the cost to benefit ratio there, because people's whole lives derail. And my biggest point to this is that they end up with, so your knees go where your ankles go, and then you get excess weight on you, and you become sedentary, and the next thing you know you have diabetes, and the next thing you know you have heart disease, and it's the sequelae into the grave, right? Yeah. And it all started with that football injury or that knee, that whatever it is, and you see this too, right? And it's, to me, finding the root cause is really helping people get over their pain and getting that handled so then they can move on to the hard work. But don't get caught in that trap of, it started with a gimpy hip and it's turned into 200 pounds later kind of thing.
Yeah. Well, it was my own experience. So I had knee surgery. They put me in a knee immobilizer, which just basically meant my leg was completely straight, immobilized for 6.5 weeks. I got out of it. This quadricep muscle, my left quad, was as big as my right calf muscle.
Wow.
Trying to regenerate it with this massive scar, inhibiting my muscles. And then when I was in the immobilizer, I was like swinging my leg around and I jacked my hip up basically, or I stretched my ligaments. So I'd get adjusted and my legs feel great. And then a couple of days later, this knee would start feeling weak. I'd get my low back adjusted and it'd feel great. And then you're like, I bet your ligaments are just deformed. And so you worked on the SI.
We treated your low back.
Twice. And
we treated the muscle.
Yeah.
Just really getting the whole clinical picture figured out, I think is important.
So she's been a blessing to me. And honestly, this information, so many people need to know.
Yes.
So share this with your friends and family, like the video, pass it on. But this is something that needs more attention, and she's obviously a great person to learn from if you're a practitioner. And hopefully this interview gives you a lot of information and empowerment and choices that you can start looking at. So we'll do some more with her because she is awesome. But, thank you so much for being on the interview again.
Thank you so much. Yeah, thanks for having me.
And we'll see you guys soon.
Thank you for listening. If you enjoyed this episode or found it valuable, please leave positive feedback, as it will get the message out to those searching for answers to their health issues. You can find more information and resources at drjdavidson.com. That's DRJAY Davidson.com. drjdavidson.com.